Hello and welcome to Journal Club this week. So this week we've got a presentation from Jamin who's going to present about STARRT-AKI. So I'll hand you over to him to start the presentation.
Hi everyone. So this is a recent article actually just published this year in the New England Journal of Medicine. It's basically looking at timing of initiation of renal replacement therapy in AKIs within the critical care setting. So I know, well, the question I've had on the ward is, do we wait to start dialysis, or should we start earlier? And this is what this study looks at. So I know we talked about this with Dr. Popple yesterday, just a bit of background with AKI. So it's very common in critically ill patients, and some studies have shown that at least 2/3 of patients in ITU develop some sort of AKI, and up to 50% of these need dialysis. There's a rationale for early dialysis, and that's to achieve optimal fluid balance. Does it have an impact on 90-day mortality, and also an early correction of metabolic acidosis, in particular conditions such as sepsis and things like that? And then the rationale for delaying your dialysis is obviously inserting VAS caths have got their own risks of infection, damage to structures, pneumothoraces, and also avoidance, because some patients will actually improve without needing filtration. So just a brief background, looking at previous trials which have looked at this. So the STARRT-AKI trial looked at predominantly medical, so it wasn't anyone in ITU. And they randomized early to late dialysis. It wasn't ITU, but it wasn't looking at any surgical patients. And they showed there was no difference in mortality, dependent on if you started it late or if you started it early. And then similar other trials have shown that the ELANE trial showed that there was a difference in mortality favoring early initiation of strategy. So starting dialysis with an AKI in the first 12 to 24 hours. And then the IDEAL study just looked at people with septic shock, and this didn't show any difference. So this STARRT-AKI study is a much larger study than the other ones. And I feel like it might shed some more light into should we start dialysis early or should we wait? So again, just a brief recap of background. So I think most of you know the indications for renal replacement therapy after we went through yesterday. So there's refractory uremia, so causing encephalopathy, pericarditis, fluid overload that hasn't got better with diuretics, refractory metabolic acidosis with a pH of less than 7.2, and then hyperkalemia, refractory to medical management as well. And then other indications include toxins, temperature control, and sodium greater than 160. So just going into the design of the trial, so there was a one-to-one randomization, and then there was concealment allocation. There was quite a large sample size at 2,866. How few of them were lost to follow-up or were discounted from the trial. And each of them had specified subgroups, including patient, sex, their previous EGFR, and if they were surgical medical patients. If they weren't able to consent, then written consent was gained by their relatives as well. So as I said, it was quite a large study. So it looked at 15 countries and 168 different intensive care units. And they were randomized between 2015 and 2019. So just looking at inclusion criteria, so you had to be greater than 18 years old, had to be admitted onto ICU. You had to have an AKI, so either creatinine, going by your creatinine greater than 100 or 113 men, and also evidence of a twofold increase in creatinine from baseline, and reduced urine output as well. You had exclusion criteria as well. So your potassium, if it was greater than 5.5, that was excluded because they would normally just go on to early dialysis anyway, as well as bicarb less than 15 because they might need early dialysis and couldn't be randomized to starting it later on. Similar to that, drug overdose, and then any renal replacement therapy in the last 2 months. So any people who are on dialysis or in kidney transplant, they were excluded as well, as they were more likely to need early dialysis regardless of whatever condition they had. So once all inclusion and criteria was met, then they were randomized either to being started dialysis within 12 hours of getting to intensive care, or they were put on basically a normal protocol. So you would wait until they actually needed dialysis. So they had hyperkalemia, which was refractory, or they needed temperature control later on, but not immediately. So as I said, there's split between about half between 3,000 patients, so 1,500 in the accelerated and 1,500 in the standard arm. And then as I said, few were lost to follow up. Just looking at, obviously we look at baseline characteristics, and overall they're very similar between the two groups. So the average ages, the average baseline creatinine were very similar. So there wasn't any patient bias that was seen in the study. So when we look at the intervention, if we start off with the patients who were in the accelerated arm, quite a high proportion actually received that intervention. So 96.8% of them received dialysis in the first 12 hours, and the average time was 6 hours. And then the average creatinine, as I said, there is 327. Control, so the clinicians had the overriding decision of when to start the renal replacement therapy. So that's what we standardly do on intensive care. So if they've got uremia which needs treating, or you've got potassium which needs treating, then that would be up to the clinician specifically. And they had to fit the other inclusion criteria, so persistent AKI and creatinine of 50% more than the recorded at randomization. And they had to show that they had an indication for dialysis. So as I said there, what we would normally do on intensive care, so potassium, pH, fluid overload. If a patient was in the standard group and the clinician thought that they actually didn't need renal replacement therapy, there was no obligation for that to happen. So this could be that they were getting better, being medically managed, or fluid overload was okay in that perspective. 61.8% of the patients in the received dialysis at that time. So I talked about the outcome of the other studies. So the primary outcome, looking at 90-day mortality, there was no significant difference at all between the two groups, which is quite reassuring, because I think on intensive care, sometimes we see these patients day after day and we see their urea and creatinine going up and the urine output just dropping slightly. And we think, should we have dialyzed them on day 1 or day 2? But if you look at that, there was no actually difference between the two. They look at secondary outcomes as well. So they looked at dependence on renal replacement therapy, which they did show to have a significant difference in the patients who had early dialysis, and a slightly shorter stay in ITU, but only by 1 day on average. There was no other significant difference in morbidity or other causes of mortality. And the EGFR at day 90 as well, there wasn't a big difference. And they also looked at renal replacement therapy 3 days at day 90, which there was no significant difference in the two. I spoke about earlier that the argument for delayed dialysis is potential risks of procedure, such as infection and things like that. And it was actually shown that patients who were started on the early dialysis had more adverse events, 23% compared to 16.5%. These include things like line sepsis, hemorrhage, pneumothoraces, and other things like hypotension, which is caused by being on the filter, and hypophosphatemia as well. But that looked at just moderate and mild ones. In terms of serious adverse events which cause the patient significant harm, there wasn't really a significant difference between the two groups. So just looking at the strengths of the study, so there was allocation concealment, there was blinding to the assessors and the clinicians, and there was also a large center size. So there was, I said, 15 countries and 168 ITUs, so it had a wide variety of different inputs from different countries. And it also had a pragmatic design, so it reflected the real world situation in terms of the clinicians would, in the control group, had the overriding decision on whether or not they were not going to start dialysis. And there was no funding involved from other organizations that could cause bias. The weaknesses, although the clinicians had an overriding decision in the control group, the rationale can sometimes be difficult to define. So as we know, a lot working day to day with different consultants, sometimes they have different thresholds for decision making and starting dialysis. And this wasn't really looked into in terms of was there a wide variety between different countries or even different ITUs within the study. And also another point we looked at was starting late dialysis. How much of an economical impact would that have in terms of saving filter sets, saving lines? Would it have a massive cost saving as well? So just briefly looking at the conclusions. So main one is it didn't show a change in 90-day mortality. And as I said, in early dialysis, it actually increased your risk of dependence and also adverse events secondary to the placement of the lines. Any questions? How do I get this thing on?
Okay.
Yeah.
Thank you, Jay, for your good talk about AKI and renal replacement therapy. So I have got a question, actually.
Yeah.
So obviously you've raised a good point there. Do you think it's worth now waiting then, rather than dialyzing someone in the first 24 hours? Do you think it's worth waiting given this trial and what it's shown?
I think we should wait for standard clinical practices. So what we do normally on ITU. So waiting for refractory hyperkalemia or fluid overload that may impact ventilation. I think what we're doing now is the correct way to do it, rather than thinking that their urine output is falling slightly or the urea and creatinine is increasing. So I think that what we're doing is the right way to go about it.
But what exactly is the way? How do we determine precisely when the VAS cath? Because surely different consultants are going to decide when the VAS cath is going. So.
Well, I think VAS cath going is different to starting. I think when we make the decision for dialysis, then I think the VAS cath should go in, because otherwise you've got the risk of inserting a risky procedure without any benefit or any use of it. So once a decision for dialysis is made, and we've got clear indications of those, I think the not softer indications would be toxins and temperature control and potentially hyponatremia. Those can vary quite differently, but the other ones I think most clinicians would have the same indications. So the four we talked about yesterday with Dr. Popple, so your uremic with encephalopathy or pericarditis, your hyperkalemia, which is not treatable, your fluid overload, which you want to offload them. So I think most clinicians will have the same indications on those major ones, but the other ones I think may be softer.
Okay, thank you. Does anyone else have any comments or questions? Yep. Have you got your...
So I just have got one question. So did this study actually looked into what is the impact of the number of days the patient are on the dialysis if they are started earlier or late?
No, it didn't.
Because is it any beneficial to start early and so that they can come off early, or if they start late?
We looked at renal replacement therapy 90 days after 90 days, how if they needed ongoing, and there wasn't a difference between the two. But it didn't actually. I couldn't see anywhere that looked at how many days they were actually on dialysis. No.
Okay, fine.
Okay, do you want to, Dr. Naya, do you want to say your question?
Hi, Jay, are you able to hear me?
Yeah, I can hear you. Yeah.
Okay, thanks for the presentation. Well, I just only had to catch up just in between. I just wanted to know the standard arm. You said accelerated arm and the standard arm. The standard arm, when they commenced, how soon did they commence the dialysis compared to their accelerated arm?
So it was normally, well, I think the average time was about 72 hours if they needed it.
Okay, 72 hours. That's the time they commenced, not the duration they provided.
No, the time they commenced between the average time. Obviously, some of them got started earlier, and some of them didn't need dialysis. But only 60 in the standard arm, only 61% of the patients actually went on to dialysis.
And when did they stop? What was the criteria to stop?
The criteria was clinician's decision for that.
Okay, all right. Okay, thank you.
Like intensive care. So basically, the standard arm is the normal practice we do, and it's up to the clinician looking after the patient. But the accelerated arm, it was pushed to start dialysis within 12 hours of being admitted to intensive care, if they fit the inclusion criteria of having an AKI with greater than 50% of baseline plus either metabolic acidosis or hyperkalemia, and not waiting for that medical management in a sense.
And then in the accelerated arm, you said that the conclusion was that there were a lot of more dependence on the accelerated arm compared to the standard arm.
Yeah.
Okay, though
So
it didn't.
a lot more patients needed to go on. They needed to go on to either dialysis further on the renal team, more than the standard.
But they had a less number of days of stay in ITU.
Compared to 10. So, yeah.
Okay, all right, thank you.
I'd be really interested to hear about the economic benefit of actually waiting, because it seems like, you know, that if more people had to have dialysis in the accelerated arm and more people were dependent on it afterwards. So I think it would actually be more expensive in the long term rather than just saving one day of ITU cost.
Exactly. I think that's an interesting point. I think the reason they looked at it was, would it cause a difference in mortality? Would it reduce their days, the number of days in ITU by a significant amount? And if it doesn't, then there's no real clinical indication to do that. And I think you're giving the patients more harm than any benefit, in a way.
But it also depends on the incidence of complications.
Yeah.
So it's not just a like-for-like comparison, because you're looking at the incidence of how often.
Yeah. Yeah.
It's a bit more, because one day on ITU still costs a lot of money. So it's not necessarily that easy to compare.
And also, I guess you're looking at the number of filter sets you're getting through as well, so how much do they cost in terms of the fluid bags as well, and just comparing how much you're getting through, I guess, and then the other complications, is that going to extend their stay by a bit longer?
Okay, thank you. Has anyone else got any questions? Anyone that wants to say anything, write it in the chat. Anyone else? No, it doesn't look like it. Okay, thank you very much, everyone. Really good paper, really enjoyed it. Thank you, Jamin.
Well done, Jane.